Welcome to our webinar titled Beyond the Kidneys, the Whole Body Impact of ADPKD. This is the third of four webinars in our series titled Confidently Navigating ADPKD, Understanding the New KDIGO Guidelines. My name is Paul Scribner, Vice President of Community Programs and Education, and I'll be moderating the presentation today. Our presenting sponsor today is Otska, and we'd like to acknowledge Otska for their support of this webinar through an independent sponsorship. Please note that the PKD Foundation has maintained full control over speaker selection, content, and this session is intended to provide unbiased, evidence-based education for our community. KDIGO stands for Kidney Disease Improving Global Outcomes, and they're a global nonprofit that brings together experts to create trusted research-based guidelines in kidney care. Their guidelines were created over about a 3-year period by an international expert, including doctors, researchers, and patient advocates. It focuses on ADPKD, so diagnosis, slowing progression, medical and lifestyle, mental health, monitoring strategies. It addresses the whole body impact across life stages, and of course, that's the topic for today. It includes recommendations on things like liver cysts and brain aneurysms, pain, emotional well-being, etc. And finally, it encourages shared decision-making throughout, meaning having those collaborative conversations with your healthcare team to make informed choices that align with your personal goals, your personal values, and your lifestyle. Our presenters today are Dr. Craig Gordon and Dr. Pranav Garimella. Dr. Gordon's a nephrologist with expertise in hepatitis C and chronic kidney disease, PKD and kidney transplantation. He's held academic and leadership roles at Boston Medical Center and Tufts Medical Center, serving as a renal fellowship program director and course director in renal pathophysiology. He is actively involved in clinical research and guideline development, and he has contributed to the KDIGO guidelines. He's also director of the PKD Foundation's Center of Excellence at Tufts Medical Center. Dr. Garimella is a board-certified nephrologist with expertise in chronic kidney disease and polycystic kidney disease, kidney stones, and metabolic bone disease. He's director of the PKD Foundation Center of Excellence at the University of California, San Diego, and co-chair of the PKD Foundation Center of Excellence Advisory Committee. So at this time, I'm going to turn things over to Dr. Craig Gordon to get us started with cardiovascular and liver involvement in PKD. Dr. Gordon.
So once again, I'm Craig Gordon. I direct the PKD Center at Tufts, and I'm going to, in the next 20 or so minutes, cover cardiovascular and liver involvement in ADPKD. You just heard about the KDIGO guidelines. I can't emphasize enough how important these are. They were published in February of 2025, so just a few months ago. And there are literally specific chapters addressing the two issues I'm going to cover today, which is the issue of cardiovascular disease and intracranial aneurysms, and a separate chapter on liver disease as it relates to ADPKD. And if you go to the website at KDIGO, there are patient-facing materials as well. So it's not just physician-focused, and there are information that you can directly utilize yourselves. So beginning with cardiovascular involvement in ADPKD, my focus is going to be entirely on intracranial or brain aneurysms, because I think this is something that leads to a lot of consternation, not just in the patient community, but also among the treating medical community. And so KDIGO actually took this on very seriously and put together this figure to educate patients about the symptoms of what we call the thunderclap headache in medicine. And this is a headache of an aneurysm rupture. And I've taken to describing this to pretty much every patient I see in the clinic now, because I feel like someday someone's going to act. I really hope no one on this call, and I hope none of my patients ever experience this, but I want people to know what to do. So what we mean by a thunderclap headache is it's a sudden headache of severe intensity. It goes from really 0 to full intensity in less than a minute, often described as the worst headache of my life. So this is very different than a tension headache or even a migraine headache that have a slower onset and maybe, although they can be quite severe, don't get to worst headache of my life status. we want you to get medical attention before we even get to this purple box of other symptoms related to the bleeding, which could be nausea or vomiting, but more ominously, seizures or even loss of consciousness. So what I advise my patients, if you ever experience a headache like this, you immediately dial 911. And the same is true for their caregivers. This is not a take Tylenol and go take a nap situation. And uh, upon being seen in the ER, they should be doing a CT scan to look for a bleed immediately within moments. And if they don't, you need to educate them about the risk of bleeding associated with ADPKD. Hopefully, most people in the emergency room would know this, but they sometimes may need a little prompt. So turning away from that, let's talk about screening, which is what we're trying to do to an attempt to prevent these aneurysms and detect them and do something about them before they cause any trouble. Now, I will say here that the aneurysms are still quite rare, even in PKD populations, but it's just much more common than the rate of aneurysms in, let's say, the general population without PKD. And you can see in this table here, there are certain risk factors that appear to really increase a person's risk of ICA, which is intracranial aneurysm, or SAH, which is subarachnoid hemorrhage, that's the bleed. So a family history of either bleed or aneurysm, especially the closer the person is related to you, is probably the strongest risk factor. Probably equivalently strong is if you yourself already have a history of known aneurysm or known bleed. And then after that, a long history of decent volume of tobacco use would be a risk factor. And then we turn to some things that are probably lesser factors, such as female sex seems to be a little bit more associated with this than male, although all PKD genetic mutations can be linked to this. It seems it's more common a little bit in PKD1, but don't be reassured by the presence of PKD2 or even a minor gene. These individuals still are at risk. And then early onset or less good control of blood pressure appears to be a risk factor as well. And this information here about risk is what drives us to make suggestions about who should undergo screening. And the reason it's a little bit complicated is there's pros and cons of screening, or as KDIGO writes, advantages and limitations, okay? So the advantages, you might find an aneurysm that is at risk of rupture, do something about it and prevent a bleed or something serious like death later in life. You might find in the second bullet point an aneurysm that looks like it's at low risk of rupture and keep an eye on the person with serial screening testing. And obviously, if you don't find an aneurysm, you're going to help reduce a person who has anxiety about this by telling them that there is none. On the other side of things, finding aneurysms can lead to anxiety, might lead to extra testing and serial MRIs to keep an eye on it, may even lead to procedures with their own potential risk of complications, among other potential limitations. So there's a discussion to be had with your doctor about the pros and cons of this. KDIGO comes down with some stronger recommendations regarding some of the patients and some of the situations where screening really should be recommended. So a recommendation in KDIGO speak here, you can see this 6.1.2, is generally based on a stronger level of evidence than these other things down below called practice points. And so what KDIGO has written here is in a person with a personal history of aneurysm or rupture, or a positive family history of aneurysm or bleed or even unexplained sudden death in a family member, those are people who the guideline experts recommended screening for aneurysm in. If you turn to the second, this practice point here, this is less solid evidence, but probably reasonable to screen individuals who are the first person in their family to develop PKD. So that's called de novo ADPKD, as well as those who don't know their family history, for instance, people who've been adopted. Or perhaps there's so few individuals in the family with ADPKD that you can't make any determination about whether the family does or does not have a risk of brain aneurysm. And then finally, turning to this third point, is that some settings it's advised to do screening for aneurysms. Many different kidney transplant programs will require this as part of their evaluation for kidney transplant. Not listed here, but very important, is, at least in my practice, if I have a patient who is wanting this done after I discuss the pros and cons, we, in mostly, if not all cases, will agree to do the screening. And then finally, certain professions might be those where it's wise to screen. The classic example that's always tossed out is airline pilots, where, God forbid, someone in flight has an aneurysm rupture, the whole plane's at risk if that happens. But I don't think it should be limited just to those people. I have patients who are way out at sea at work, and that would not be a great time or situation to have an aneurysm rupture. You could imagine all kinds of different professions where it's probably advisable to know this ahead of time. So how do we screen? The first thing to realize is it's done usually by MRI, something called MR angiography. And importantly, you don't need any contrast at all for this. So there's no MRI contrast dye required. And these tests can be done in many, many medical centers around the country that just have MRI capabilities. I will point out, though, that CT angiography is sometimes needed. This might be needed in people who cannot have an MRI for one reason or another, or sometimes we need to do it to get a better look at things. And the problem with CT angiography as it relates to kidney disease is we're required to use IV contrast dye, which comes with a small but not zero risk of causing worsening kidney function. So this needs to be considered really in the context of the patient or the person's current GFR as far as the wisdom of this. But I would say in well over 90% of cases, we're just doing the MR angiography and only very rarely need the CT. So what do we do in the event an aneurysm is found? Here we need help, nephrologists from our colleagues from neurosurgery, as well as another field called interventional neuroradiology. I would recommend that this is something that should be really done in one of the major medical centers around the country. Consider perhaps one of the PKD Foundation recognized centers of excellence. But wherever someone goes, it has to be a place with a lot of experience, because experience is not just that they know how to do all the procedures, but also equally importantly, or maybe even more importantly, they know when not to do things. Okay, so when we start doing things to patients, we can potentially cause some harm. So this needs to be a multidisciplinary decision between your nephrologist and individuals from neurosurgery. And it turns out that if you find small aneurysms in certain locations in the brain, these can just be watched with serial imaging. That means every 6 to 12 months initially to make sure they're stable. If they stay stable over time, we start widening out that interval to 12 months or even longer. But if we find large aneurysms or aneurysms in certain locations in the blood vessels in the brain, or if they have certain appearances that give the sense that there's a higher risk of potential rupture, in those situations, they may require procedurals to lower that risk of bleeding and rupture. And these are divided into two big categories. The first is procedures using a catheter, often called coiling procedures, where they basically block off the aneurysm so it doesn't have a risk of rupture. And this also can be done surgically with microsurgical techniques to do what's called clipping of an aneurysm, again, to lower its risk of rupture. In the converse, what do we do if the screening test, the MRA, is negative? Well, it turns out no one quite knows how often to screen again. KDIGO recommends we do this every 5 to 10 years, but the distinction between 5 and 10 years really comes down in my practice to how many and what's the severity of the risk factors. So if there's a lot of family members with aneurysms, I might push down towards the every 5-year range. And if there's not much in the way of risk factors, I might do less often. And I do want to emphasize before I close this topic that whether you have an aneurysm or don't, we want to address the risk factors that are modifiable for aneurysm, which include getting blood pressure under control and for those who are tobacco users, getting them to stop. So with that done, let me speak about liver involvement in ADPKD I'm referring to here. It's a little bit different in autosomal recessive PKD, which I'm not going to speak about today. And I'm also really referring to people with PKD and kidney cysts with also liver cysts. This nomenclature gets a little confusing because there's a condition called ADPLD, which is due to different mutations that cause almost exclusively liver cysts and either no or very few kidney cysts. And this is not what I'm talking about. I'm talking about people with obvious ADPKD who also have liver cysts. So here's what KDIGO says. They talk about the evaluation for for PLD in people with ADPKD. And these are kind of obvious points, but they're not small points. The first of which here is if a CT scan or MRI has been done in an ADPKD patient, take a look at the liver to see how severe or not the PLD is. You'd be surprised how many CAT scans are done for kidney stones or MRIs to determine TKV and Mayo classification, where no one's really looking closely at the liver. So this is a reminder to look at the liver. The second point is if you haven't had imaging, and you have symptoms that are concerning for potential enlargement of the liver, that's what meant by the word hepatomegaly here, that this would be an indication for us to do either a CT scan or MRI, both to take a look at the liver and the kidney. And then the final practice point here is just to inform patients about what's found. Is it many patients with PKD will have one or a few liver cysts that are usually not, especially if they're small, of any major significance, but others might have more moderate or even severe burden of cysts, and people need to know that. So why is it important? This is because these cysts can cause all kinds of problems. So just to orient those of you who don't think about anatomy every day of your life, the liver here is in sort of this brownish liver colored presentation here with cysts for different colors for reasons we won't get into. Adjacent to that in light pink is the stomach, and also represented are some blood vessels and the drainage system of the liver that drains bile here in green. And in red here is the diaphragm, which is controls breathing. So as you might imagine, if you have tons of liver cysts, you can experience abdominal fullness, issues with mobility, potential issues with fatigue, potential problems with intercourse, even mechanical back pain. So there's a lot of mechanical issues that come from just an enlarged liver. Moving to this yellow box, those cysts, similar to kidney cysts, can bleed and we can have cyst hemorrhage. They can become infected, which require treatment. They can also block the drainage of bile, leading to jaundice, which is yellowing of the skin, or least likely can cause obstruction to the blood flow from the liver, causing reduction in liver function and even rarely liver failure. If the liver is very close to the stomach, this can press on the stomach and cause what we call early satiety, which means people get full easily, or evidence of acid reflux or heartburn, as well as nausea, vomiting, and weight loss. And if the liver is pressing up against the diaphragm here, represented in red, people can experience shortness of breath. So it turns out significant PLD is much more common in women than men. It occurs earlier and generally is more severe. And the people who more likely require treatment of PLD are much more likely to be women. And this is thought to be due to the female hormone estrogen. And some evidence that points towards this is if you look at young women less than 48 years of age, which are probably premenopausal, In women older than the age of 48, likely postmenopausal, you can see here the rate of liver growth was about 2.7% increase in size per year in the younger women and less than 0.1% per year in the older women. Again, this is thought to be due to the estrogen. And so the importance here is there's a potential significance on the impact of using estrogen containing birth control or oral contraceptive pills, as well as hormone replacement therapy or other situations of high estrogen. And I think KDIGO had a very nuanced approach to this. And I think the important message is to try to avoid unnecessary estrogen exposure early in life. It may be that oral contraceptives are needed either for birth control or for endometriosis or other symptoms. But if it's possible, try to avoid estrogen containing medications and try to find other forms of birth control or contraception that are equally effective but don't contain estrogen. And this is true for women with ADPKD, whether or not we know that they have PLD at baseline. We don't, even though pregnancy is a high estrogen state, we don't discourage pregnancy. We're not quite clear on if there's an impact of many, many, many pregnancies or the very high estrogen state of IVF. And what we've done in practice is people who are considering either IVF or after many pregnancies, an additional one, will often re-image the liver to see what it looks like compared to the previous studies to tell our patient, yeah, you're fine. You can go ahead with what you plan, or let's rethink about this because the liver got worse compared to a few years ago. So let me just talk in the last moments about treatment of PLD. Again, similar to what I said about brain aneurysms, you want a multidisciplinary team of liver specialists, liver surgeons, interventional radiologists, et cetera. This again needs to be at a major medical center who have access to all or most of the treatments I'm going to speak about in the next slide or two, and also the wisdom and experience to know when not to treat. So this is an approach from a European guideline, basically beginning with PLD here on the left. If you make this diagnosis, you want to stop exposure to estrogens. If people don't have cyst-related symptoms, you don't want to do anything. You don't treat people who don't have symptoms. But if they do, the treatment depends on the severity of the disease. So you can see the liver is represented here in yellow and cysts in red. So if you have one large cyst, you can drain it and then put a sclerosing material to scar it and prevent it from reaccumulating. This is called aspiration sclerotherapy. If you have a bunch of adjacent cysts, you can do a surgical procedure called a fenestration to try to drain them. If you have a region of the liver with lots and lots of cysts, but other areas of the liver look okay, now we're getting more invasive, but we can consider a partial resection of the liver and let the remaining liver tissue do its job. And actually, there's even regeneration of the liver. But if you look at this image on the bottom where the liver is absolutely riddled with cysts, that may actually, in some cases, require liver transplantation. And then finally, coming back to the top here, if you have a modest or even severe degree of liver cystic involvement, but nothing that requires procedural intervention, there's a medical treatment called somatostatin analogs, such as octreotide, that can be used. So just covering these in the last moment in a tiny bit more detail, here is the aspiration sclerotherapy. This is again done for one or maybe two large symptomatic cysts. You can see symptoms improve in 70 to 100% of cases, and cyst volume reduction is seen in a similar percentage of the time. Minor complications are seen in up to 5 or more percent of cases. Now, I will say minor to physicians is not always so minor to patients. So I don't want to at all be blasé. These are, people can have lots of pain and other issues or infections. So these are nothing to be undertaken lightly. The partial hepatectomy is above where I just highlighted, but basically this is where you remove a portion of the liver and leave the rest in place. As you might imagine, this is a big surgery with higher rates of complication, but not quite as severe as the complication rate of liver transplant, which is really a desperate situation where there's just tons of symptoms, loss of muscle mass from this. And we're really trying hard not to get there, okay? And this brings us to finally the somatostatin analogs, which is a medical treatment. It's an injection. It's a very viscous fluid, so it's not something that people really can do at home. We do it with our one of our nurses. People come in once a month to receive this treatment. But this treatment results in reductions in the growth rate of liver cysts and is generally well tolerated. People can have some GI side effects. Occasionally, you can get high sugars and even diabetes and a higher risk of gallstones. But the real issue with this is, we have patients coming from sometimes 3 hours away once a month to get this injection. So I think that was a very quick overview of these two really important conditions. And I thank you for your attention. And we'll turn things over to Dr. Garimella.
Thank you so much, Dr. Gordon. I appreciate that. So with intracranial aneurysms and liver disease out of the way, I wanted to spend some time talking about some of the other, perhaps less commonly addressed complications, as I would think of, with regard to the kidneys, bones, and some of the metabolic complications that we see in PKD. And some of these are common to all chronic kidney disease states. That's my disclosures. As we have heard before, I do work with the PKD Foundation, and I have some NIH research support as well for that regarding PKD. So for the next 20 minutes, I'm going to give folks a high-level overview of what we think about as the most common complications that occur in PKD with regard to the kidney, the urinary tract, and bone disease. And this really relates to pain, episodes of bleeding, urinary tract infections, and the consequent complications, which could be sepsis and long-term antibiotic use. And I'll touch upon kidney stones a little bit, and then wrap up talking about bone and mineral disorders, which are more common to the entire spectrum of chronic kidney disease, not just PKD. So if anyone's leaving after the next 5 minutes, this slide will probably give you a 10,000-foot overview of what the guidelines recommend, and that's what I'm going to list. So in people who have kidney stones, counseling should be targeted so that they achieve a daily urine output of at least 2.5 liters a day. Again, this is not how much fluid they should consume, but really how much urine they should make. And why is this important? Because the more urine volume that is achieved, the more dilute the calcium and oxalate, and the supersaturation of these chemicals is lowered, meaning that there's less risk for stones. In people with PKD who have known stones, we should get a 24-hour urinary testing for stone risk. So physicians should order a 24-hour urine collection and assess the chemical composition of this to understand whether the risk is changing over time. And we could also consider kidney imaging, preferably using an ultrasound, because we don't want to expose people to radiation and evaluate what their stone burden is, especially if symptoms have changed over time. In people who have kidney disease and have a high uric acid level or a history of kidney stones, since they're all tied together, it is not unreasonable to consider urate lowering therapies. So medications such as allopurinol, febuxostat, or some of the newer drugs to reduce the urate levels in the blood so that we have less episodes of gout and perhaps kidney stones. In people who have uncomplicated urinary tract infections, most of the antibiotics that are prescribed for non-PKD patients would work just fine, especially since we're talking about infections that are primarily still within the bladder or the ureters, and maybe not in the cysts yet. However, if people have a suspicion for cyst infection, so if there are recurrent infections, fever, tenderness, and pain, KDIGO would suggest treatment with 4 to 6 weeks of antibiotics rather than a short course. So we're not talking about 10 days or 2 weeks, but really 4 to 6 weeks. And I think that's important to remember. Any of these conditions above can cause chronic pain, and you can have pain without any of these conditions as well. You may not have stones, you may not have cyst infection, but you can still have stones, still have pain. And the refractory chronic pain is unfortunately common enough that it is best managed by a multidisciplinary team. And really, a stepwise pharmacological therapy for this pain needs to be formulated, especially when non-pharmacologic interventions are not adequately working. So with that in mind, I'll talk a little bit about pain in PKD. And as you can see here on this cartoon, there are several causes of pain. On the top left here, you have the pain due to a ruptured cyst. This could be sharp, sudden onset, and also to an infected cyst. And it's important to distinguish these, and I'll talk about this a little later. On the top right, we have ruptured liver cysts. So Dr. Gordon just gave us an overview of liver disease, and we know that some of these cysts can be really large, cause compression, and if any of them rupture, that can be a sudden pain as well. Kidney stones, whether or not you have PKD, kidney stones typically cause an acute sharp pain, and that ends up leading to most people seeking medical care immediately, given how severe it is. And lastly, even if you don't have any of these acute issues, chronic pain just from the size of the kidneys and the size of the liver and the compression that they cause can be quite debilitating and needs to be addressed. And if you look at this data from the PKD Foundation registry of over 1,000 patients who completed specific questionnaires related to pain, you can see that the different kinds of pain, sharp pain, dull pain, or fullness and discomfort are pretty common. This is patients being asked how many times over the last 7 days did they experience it. And you can see that there are patients who report almost daily pain. And the severity of this pain seems to increase as kidney function decreases, probably reflecting the fact that as kidney function decreases, your kidney volume, the size of the cysts, is increasing. So it would make sense that as the kidneys get bigger, the likelihood of complications and pain is more. And with this comes the additional loss of quality of life. And you can see here the dark purple boxes here represent what people responded to about how much this pain affected their sleep quality. So this is just sleep quality, but people report this about the ability to work, the ability to carry out activities of daily living. And so this is something that needs to be addressed with the clinical team. And I encourage everyone to bring this up on a regular basis if your physicians and treating teams have not asked you about pain. There are several strategies to control the pain, but I think the first thing is you'll see up here on this box is shared decision making depending on what's available. Now, if someone has chronic pain, which has been there for over 3 months, there's a different algorithm, and I'll talk about that in the next slide. But on this slide here, I really want to focus on sudden onset pain that came up in a day, that came up in the course of a few hours. And whether or not it's associated with fever and any other urinary tract symptoms is, I think, a big determination, because getting antibiotics into patients to treat an infection is of essence. And so time is of essence in that situation. Sometimes they may have nausea, vomiting, and flank pain, and that could be suggestive of kidney stones. And if there is low blood pressure and a lot of blood in the urine, that could indicate a hemorrhage in the cyst. And while blood pressure monitoring, hydration, and pain medications form a cornerstone of all of these, you can see that depending on whether or not they have an infection, a stone, or whether they have a bleed, there are different treatment pathways, and I'll show some of them to you on the next slide. In patients who have chronic pain, once those supportive measures of hydration, rest, maybe warming have not worked, we then look to pharmacological treatments. As with most pain management, we try and pick the most benign medications, which are typically Tylenol, and try and avoid NSAIDs as much as we can, because we don't want kidney and GI adverse events, and also perhaps tramadol. If these don't work, we try and move towards medications that may have more of a neuropathic effect, so work on nerve-related pain, such as gabapentin, pregabalin, or tricyclics. And sometimes we can use octreotide and maybe even tolvaptan. The third line, if none of this works, is really moving towards opiates because we want to try and keep opiates at the lowest dose for the shortest possible time. And if opiates don't work, we then try and evaluate whether these patients qualify for any kind of invasive or interventional procedures. And depending on whether we think this is kidney-related pain, we could refer them to anesthesia for a nerve block, and I'll show you some images later, or even denervation, which is essentially burning the nerves that supply the kidney to try and get rid of the pain. And if none of this worked, finally, we could try cyst aspiration or sclerotherapy, which is injecting the cysts. And I'll show you some figures about it, what that looks like. And lastly, if none of these, what we call percutaneous or the relatively outpatient procedure work, we may need to consider open surgical procedures or even a nephrectomy. But that is really the last resort for anybody because these are quite invasive procedures and have a fair bit of recovery and complication risk. So to give you an idea, this is an example of a patient. This was a 33-year-old woman with severe flank pain, and her kidney volume was quite large, about 1,000 ml. And you can see here the left kidney, there is this huge cyst, and she was having a lot of pain related to it. And so this is after a foam sclerotherapy. So foam sclerotherapy is when either alcohol or sodium tetraethyl sulfate, two components, are injected into the cyst, and the patient is made to stay there for a few minutes, and then it is extracted out. We hope that the cyst shrinks in size, and you can see here that the volume went from about 1,000 ml down to about 750 ml with improvement in the pain and perhaps even stabilization. This is creatinine clearance or measure of kidney function, and there was some stabilization of kidney function here. And as you can see, if for people familiar with the Mayo class, you would expect the larger kidneys to have a higher risk. So the Mayo class also improves by cyst volume going down. In patients who cannot tolerate that or who have too many cysts where you can't identify one single cyst, doing what's called denervation is a procedure that can be done. But again, this needs specialized centers of excellence. Essentially, this is the aorta or the large blood vessel, and a catheter can be put up it as though it's similar to patients who have a cardiac angiogram. And through that catheter, you see this white line here is in an actual patient. This is the catheter. This is going into the kidney. This dashed outline is of the kidney. And they burn the nerves right here in the pelvis so that the pain signals from the kidney come in. On the right of this figure here is a patient who is getting an injection to the celiac plexus. This is a bundle of nerves that are deep in the abdomen, and blocking these nerves using anesthetic medications can also help minimize pain or at least give relief for a certain period of time. Cyst-related bleeding is unfortunately common, and most people with PKD will see blood in their urine. 2/3 of people will have overt blood that they can see at some point in time. Most commonly, it occurs when there's hemorrhage, when a cyst ruptures, when there's trauma. It can happen with urinary tract infections and also with cancers, rarely. It's important to know that most of these are self-limiting, and making sure that patients get enough of rest and hydration, especially if there's been recent trauma, and using pain medications that don't have non-steroidals are important because non-steroidals can actually increase risk of bleeding. And sometimes if the bleeding does not resolve and it's been going on for a week, and if the hemoglobin has dropped, it's important to get evaluated as an inpatient. Sometimes an angiogram may be needed. Embolization, which is a blocking off of the vessel supplying that specific kidney, may be needed. But sometimes getting away with medications such as tranexamic acid, which has been tried once in a while. In fact, in this case that I'm showing you here with the arrow, you can see that large collection that was blood, and this patient was treated conservatively by tranexamic acid, and the bleeding resolved. So it's important to know when to contact your physician. But if you've never seen blood and you have blood in the urine after the age of 40, it's important to also get imaging to make sure that this isn't cancer. And if none of that works, if none of these interventions, sclerotherapies, or renal denervations work, sometimes patients need to have that kidney removed. And there's a huge debate as to what the optimal timing is whether you should take one kidney out, whether you should take both kidneys out. And there is unfortunately a lack of clear guidance. Right now, KDIGO has a soft recommendation that if there is one kidney that is thought to be causing pain or infection, that one kidney should be taken out. And if the patient is undergoing transplantation, that kidney should ideally be taken out after the kidney transplantation so that kidney function doesn't drop before. But again, what I've seen is that practices vary. And ideally, if someone is getting their kidneys taken out, this should be done at an institution that has a history of doing a lot of these things and in the most minimally invasive approach, perhaps even using a laparoscopic approach. So I said I'll spend some time about acute pain, and I think it's really important because infections are unfortunately common. Urinary tract infections are common, and cyst infections are also common. So we tend to worry when patients have a fever, they have pain in their abdomen, and their white cell count, which is a sign of them having infection, are elevated. And if any of these are there, ideally we would like to get a CT scan sooner rather than later, especially to see if there's an abscess, if there's blood anywhere. If there are concerning features that this is likely a cyst infection, it is also prudent to get our radiology colleagues involved to try and get that fluid out to understand what is growing, what the culture of that fluid shows, so that we can tailor the antibiotics accordingly. Sometimes, though, it's hard, even if you do a CT scan in the setting of symptoms, the imaging is not very suggestive, and we may need additional techniques such as a PET scan or an FDG glucose scan, which is more sensitive. And I'll show you an image here in a second. On the right, this image that shows you a regular CT scan in panel B and an FDG scan. So there is a tracer that is injected, and you can see here in the kidney, this circle here is indicative of an infected cyst. And so sometimes, despite this, it's hard to diagnose. And I think the level of suspicion has to be high, and the imaging has to be done right when the infection is ongoing in order to diagnose it. But like I said, 4 to 6 weeks of antibiotics are critical. Kidney stones, like I said, are quite common. Nearly 1 in 4 persons with PKD will have it. And the symptoms can be difficult to tease out from an acute infection or cyst bleed, because you might see blood in the urine, you may have nausea and vomiting, and you could have chills and fever. So the only way to conclusively diagnose or exclude kidney stones is actually to get an image. And here's an image on the left side. You see here, this patient has what we call large staghorn calculus. Essentially, it's obstructing the entire renal pelvis, the kidney pelvis. And so something like this actually needs surgical interventions. But in people who have smaller kidney stones seen on imaging, making sure that urine volume is high, limiting the salt intake to less than 2 grams, and maintaining a healthy weight, all of which also work to lower cyst growth, are important for decreasing risk of kidney stones. And we know that patients who have PKD already get more imaging, but there's evidence that patients who have PKD get more imaging very often because this is driven by stones. Kidney stones are so common that they cause all these symptoms. And sometimes, especially if they already have a history of stones, it's important to rule out an obstruction or a blockage in the kidney, which may be causing a change in kidney function. And so this study from Yale, looking at over 800 patients with PKD, showed that stones are really the driver behind patients coming to the emergency room and getting imaging done. For those of you who've heard of tolvaptan to slow kidney disease progression, you'll be glad to know that in addition, tolvaptan also improves stone risk. In fact, in the Tempo 3-4 trials of tolvaptan, the risk composite outcome, where they used a stone outcome in that, was lower. In addition, tolvaptan lowers levels of urinary uric acid and brucite, some of those minerals that cause kidney stones to form. And it also increases urine levels of citric acid. And this citrate is actually protective against kidney stones. And lastly, because calcium oxalate stones are the most common, we see that even calcium oxalate stone risk is actually lower, because the excretion, the amount of calcium oxalate that gets into the urine, is actually lower with tolvaptan. But like I said, if there are obstructing stones, those are quite challenging to treat and cannot be managed medically. And so really making sure that there is an expertise in urology or surgery that can manage these stones is critical when patients are being referred from nephrology practices. And I'll spend the last couple of minutes talking about chronic kidney disease and mineral bone disease. And you won't find these guidelines really in the KDIGO guidelines because these aren't PKD specific, but rather extend across any form of kidney disease. What we call CKD, mineral bone disease, really refers to the constellation of complications leading to fractures, increased frailty, and cardiovascular disease. And we diagnose this looking at lab abnormalities, imaging showing increased stiffness in the blood vessel. And when we look at the bone or parameters of bone health, we see that they are abnormal. And historically, we've always separated out osteoporosis, which occurs in everyone, and an entity called renal osteodystrophy, which just means kidney-related bone disease, as another component. But we know that there are overlapping features, and really the renal osteodystrophy is due to global disorders in bone strength. And this could be decrease in calcium, this could be decrease in mineralization, and even osteoporosis. And what we know is that some of these abnormalities can be picked up early on. On the x-axis here is stage of chronic kidney disease. So this is chronic severe kidney disease, stage 4 or 5. This is mild to moderate kidney disease. And these are some of these uremic toxins that we can actually measure. And all of them start to go up by the time people reach stage 3. And this is when the bone turnover starts to change into a really low bone turnover, making a risk of fractures high. And then it can actually increase to a high bone turnover. And understanding where the patient is on the spectrum is important because the treatment for osteoporosis with high or low bone turnover is completely different. And so it's important that patients are provided with the information, especially when they have bone disease. So if you have a loved one or if you have bone disease and osteoporosis and you have chronic kidney disease, it's good to actually discuss that with your nephrologist because a lot of what is happening through the kidney or to the complications of the kidney dictates what the diagnosis is and what the treatments can be. And this interplays with the cardiac disease with vascular stiffness. It causes osteoporosis. And there is interplay with diet, uremic toxins, endocrine hormones, and even the immune system. And so we've moved away from a simplistic model of, oh, there is low calcium, and so there's osteoporosis, to a more nuanced framework where we have an increased risk of bone-related disease that's probably built on an entire imbalance between multiple organ systems in the body. And lastly, how do we manage this? Well, again, it really comes down to what is important to the patient. For instance, I used to run a bone biopsy program here at UC San Diego where we would do biopsies of the bone. You've heard of biopsies of the kidney, but we would actually do biopsies of the bone in patients with advanced kidney disease to actually get to understand what that high bone turnover disease is. Is it low? Is it high? Do we need to treat them with traditional osteoporosis medications or not? If they're on dialysis, do we need to inform their dialysis doctor about what the calcium and phosphate parameters in the bone look like? And should their treatment times or treatment prescriptions change? And whether we can do anything with their medical therapy to manage this is also something that really needs consideration. So again, a lot of things go into the management of bone disease in chronic kidney disease. This isn't just PKD, but really if anyone with PKD has advanced enough kidney disease, you will encounter these complications, especially if you reach dialysis and transplantation. So don't be afraid to talk to your kidney doctor about your osteoporosis. And this is why we really need this multidisciplinary team. I need my radiologist. Like Dr. Gordon said, we need liver specialists, we need neurosurgeons, we need our transplant surgeons, we need our dietitians in order to actually manage PKD. Because while the kidney function is what most of us end up focusing on, this is a spectrum of conditions that really culminates in the need for multidisciplinary care in order to actually improve outcomes. And that, I believe, is my last slide. So I will stop there and I'm happy to take questions. Thank you.
Thank you, Dr. Gordon and Dr. Garimella. And we are going to jump into questions because we have a lot of questions. First question I'm going to direct to Dr. Gordon, and I'm really looking at questions that have had a lot of upvotes. Will everybody with liver cysts that cause liver enlargement eventually need a liver transplant?
Yeah, I'm so glad this question was asked. It's a great question, and the reality is most people will not progress at all to have severe PLD. In fact, the vast majority will have very mild, just a few cysts. But even those that have moderate disease don't generally end up going from moderate to terribly severe disease. So it's actually the absolute minority who need liver transplantation, a very small percentage. Part of that's because probably, especially if this is affecting women, when they become postmenopausal, the rate of cysts very likely slows. And so we don't have like growth until they're 100 years old. So this is, I think, somewhat protective, but it's a great question. So thank you
Great.
for asking.
Thank you, Dr. Gordon. Next question is for you, Dr. Garimella. Paulette is asking about her son, and he takes a lot of protein powder and wonders whether protein powder is dangerous for people with PKD.
That is a great question, something we get often. So the discussion about high versus low protein diets is strife with everything is rife with everything that confounds nutritional epidemiology. There isn't a clear evidence that high protein intake, especially if somebody is also having a healthy lifestyle, building muscle mass, that any of that is actually bad for kidney dysfunction. We have looked at low protein diets in many clinical trials historically and not found that to change the trajectory of kidney dysfunction. In fact, the MBRD trial, which was one of the pivotal trials that was done, had the largest cohort of PKD patients, about 190 patients, and Dr. Gordon can correct me if I'm wrong on this. But again, no evidence that even in patients with chronic kidney disease, if you lower protein intake, they changed everything. And so if people are maintaining a healthy diet, are exercising, are not having abdominal obesity, and they are using protein to supplement their anabolic state to build muscle mass, I think that's relatively good.
Great, thank you. This next question is for you, Dr. Gordon, and you sort of answered this a little bit, but I thought I'd ask it in a bit of a different way. This is Nancy, and she's saying she's been screened for an MRI for aneurysms, and the results were unremarkable. Is it one and done, or is it possible that an aneurysm could develop later, after screening?
Yeah, it's a great question, Nancy. And it's a really hard one to answer, actually. The studies that have been looking at this have shown not great results as far as detecting aneurysms and finding that those aneurysms that are detectable rupture. And in fact, what they sometimes found was people in subsequent testing developed new aneurysms. And I think this is part of what led the KDIGO recommendation for this 5 to 10 years for repeat imaging. But if you read carefully within the text of KDIGO, they will say that there are situations where it is one and done. And these are people who have really none of the major risk factors. So no major family history, et cetera, and had a negative study. I would think also depends on someone's age. A older individual, maybe who's had a negative study, might be in the clear and might not need repeat studying, and that might be different in a younger person. But I wish I had a clear answer to you. Our practice in my center, though, is to repeat in people willing to do it in this 5 to 10 year window. But I do know there's a lot of differences around the country.
Great, thank you. Dr. Garimella, this is Edith, and Edith is asking if someone has been diagnosed with PKD with cysts in the kidneys and liver and pancreas, are they, and this is really a two-part question, are they still considered to have PKD? And the second part of that question is, if you have your liver kidneys removed and you get kidney transplant, can the new kidney develop cysts? So there's sort of two parts to this question.
So I'll answer the second part because that's easier. If you get a kidney transplant, that kidney cannot get cysts. So you do not develop polycystic kidney in the transplant. Whether you have polycystic kidney disease, if you have a kidney transplant or have had the kidneys removed, is a more nuanced question depending on what we consider polycystic kidney disease to be. If you physically don't have the kidneys, well, you don't have polycystic kidneys. But are you still at increased risk of developing an aneurysm? Yes. Are you still, if you have polycystic liver disease, does that still fit with the spectrum of what we typically see with polycystic kidney disease? Yes. So, and then you still have to deal with the bones, the metabolic disease, even if you've had a transplant. The one good thing though is we know that people who retain their native kidneys after a kidney transplant actually have some regression or shrinkage of their cysts in their native kidneys. So that's also one reason why not everyone needs their kidneys out if there's enough space to put a kidney in. So again, depends on what we call PKD, but you don't get a recurrence. But I don't think anyone is absolutely cured of it just because you don't try.
Thank you, Dr. Garimella. The next question is from Anonymous, and this is for Dr. Gordon. While polycystic kidney disease often does not impact functionality or cause liver failure, generally, what routine testing do you recommend in terms of an MRI? I guess you sort of address that every 5 to 10 years. Maybe that there's some nuance
Oh,
to
that's
that.
for, yeah, the 5 to 10 years is for aneurysms.
For
This is a
aneurysms,
great
okay.
question.
Yep.
And the answer is you probably don't need to do much as far as follow-up. Our patients, for the most part, have had some sort of imaging, either an MRI or CT of the liver. And at that point, you know the severity of their polycystic liver disease or not. And there's not really a need for repeat imaging unless symptoms change. There's also no need for repeat blood testing. There's nothing really to follow. The liver function is fine. And a question that comes up all the time in my practice, I do want to say here, is as probably many of the people on this call know, tolvaptan, we're required to monitor liver tests. That's related, those tests are related to liver function. It has absolutely nothing to do with polycystic livers at all. So they're completely distinct. You can take tolvaptan if you have moderate or even severe polycystic liver disease. Those are completely distinct things. It's the same liver, but the impact of tolvaptan is on the cells of the liver, causing injury, totally different from the cysts. Just to reassure people who, we get this question like every week, literally.
Got it. Very good. Thank you. Next question for you, Dr. Garimella. And this is from Sue. And Sue asks, she wonders about research showing that a DEXA scan can produce false positives for osteoporosis because it misreads people in ADPKD. Wondering what your thoughts are on that. She also mentioned she's also lifting weights to maintain her bone mass.
So,
There.
Sue, first of all, congratulations on lifting weights. If anyone can lift weights, they should. Resistance training is a great reason to ensure to prevent not just frailty, but also actually improve upon the cardiovascular metabolic syndrome and obesity, all of which increase risk for cyst progression. There, I wouldn't quite think that it was just PKD, but really in patients with advanced CKD, a DEXA scan can be misleading, and especially when the PTH calcium levels are either extremely low or very high, then puts into question where on that spectrum of low bone disease you have. If someone has low bone turnover disease and osteoporosis, for instance, we wouldn't typically treat with Fosamax and the other drugs that you hear about. And in fact, that can worsen it. And that is why if someone has advanced kidney disease and they have osteoporosis, we in fact get referrals to our bone clinic, where we would do a bone biopsy to make sure that we know what we're treating.
Okay, very good. Thank you. I think this is going to need to be our last question here. This is for Dr. Gordon. And this is from Ethan. And Ethan wonders, how common or rare are aneurysms? And if you have one, is it one and done, or can you have multiple aneurysms?
Yeah, super question, Ethan. And actually, I'm really glad you asked this because I'm not sure I'm happy with my use of the word rare, which sort of spontaneously popped out of my mouth. Aneurysms are seen in actually somewhere in the 2 to 3% range of people who don't have PKD, just in the general population, which is a figure that seems shockingly high to me. In PKD, it's even higher, and it's thought to be somewhere in the, let's say, maybe 12 to 18% range, at least according to research studies. Uh, my, I'll be honest, my experience, I don't think my batting average is that high. I think it's much lower than that. And I screen a fair number of people for aneurysm, but it's not at all rare. Moreover, the point you make, Ethan, about multiple aneurysms is actually very typical. It's about 20% of the time there could be more than one aneurysm, but usually these are small and in locations where we just monitor and don't need to intervene.
Great. Well, thank you, Dr. Gordon and Dr. Garimella, for the wonderful presentation. And we had so many questions, and I am sorry we weren't able to get to all of them today. So on behalf of the foundation, I'd like to thank all of you for your participation today and your great questions. That concludes today's program. Thank you again.